It is just a huge honor for me today to be podcast interviewing Dr. Hamid Abedi, DDS, MS, MBA. He earned his dental degree from the Royal London Hospital in 1991, his MS in the Endodontic Specialty at Loma Linda University in 1995, and his MBA from UC Irvine. Dr. Abedi is an assistant professor at Loma Linda University, Department of Endo. He enjoys teaching. By the way, that's where I can't say his name, but the guy who invented MTA, methyltrexyl.
Yeah, Dr. Torabinejad.
Oh my! I'd pay someone $1,000 if I could pronounce that. Say it again.
Say it again.
Dr. Torabinejad.
You know, every endodontist always says, "When are you going to get him on your show? You've done 50 different endodontists." Will you tell him that? I mean, hell, he invented MTA, and the legend is that he was watching his. Staring at a swimming pool, having a gin and tonic, and then he watched the swimming pool maintenance man put repair mortar on the wall, and he got the idea that this cement works underwater. And I'm like, okay, I don't know if any of that's true, but I want to get him on the show and find out. But anyway, Loma Linda University Department of Endodontics. He enjoys teaching endo and has lectured extensively in his specialty field, both in the U.S. and abroad. He has served on the Professional Standards, Peer Review, and Ethics Committee for the American Association of Endodontics. He still works 10 to 15 days a month chairside. And that man next to him, you can't see the ponytail, but it's right there behind. He's trying to hide it. He's trying to look straight at the camera so you can't tell he's sporting a ponytail. Is Tom von Sydow. Comes to Cornerstone with over 36 years in the healthcare industry. Most recently, Thomas was the senior leader of all specialties and hygiene at Pacific Dental Services for 10 years with my buddy Steve Thorne, who's been on the show. He's also held senior executive positions at Nobel Biocare. Thomas holds a bachelor's degree in healthcare management from Southern Illinois University, Carbondale, and advanced certificates from Harvard in leadership and corporate strategy. He is a member-elect of the American Association of the Endodontic Foundation Advisory Board and Board Advisory for CareCru, a dental software company. He's got a wife of 35 years and spending time with his three children and grandchildren. Isn't that the best feeling in the world? That's all. I just love to do that all day. But gentlemen, I am so thankful that you come on the show because the big dilemma is, there's several things I want to talk about, and one is the fact that 8.5% of emergency room visits are odontogenic in origin. These kids come out of school $400,000 in student loans, and a person shows up in a toothache, and one of the specialties is public health dentistry, and if you can't extract the tooth or do a root canal, they're going to end up in the emergency room, and it's unacceptable that a doctor of dental surgery can't get you out of pain by extracting a tooth or doing a root canal. And they come out of school $400,000 in debt, and I swear half of them have already given up on endo. They said, I did a molar endo in dental school, and I'm not doing that again. And it's like, well, you have to do it, especially if you're in rural. If you're the only dentist in Eloy, Arizona, and someone comes in with a toothache, and you say, well, I don't do extractions or root canals, well, we got to change that for them. So I'm hoping today that you have some new things in endo that'll make these young kids want to get back on the endo gravy train. How are you guys doing?
As you rightly said, Howard, endodontists, we're kind of the ER doctors of dentistry. So our group, we have 40 clinicians, and we were working all out. And I know some of my other colleagues that were open, they were working, we were pretty busy. And I agree with you 100%. A patient coming in with pain to any doctor, whether it's an endodontist or a general dentist, as health professionals, we should be able to reassure them, minimally get them out of pain or extract the tooth, as you said. And I know, by doing that, we can keep the emergency rooms open. Because I don't know the number of patients I've had, especially in the tough times. It was pretty scary, especially at the beginning. But patients were terrified, and they were looking at us as a refuge. And my hat's out to all the doctors that kept their offices open and took care of emergencies. Because I had desperate patients who were physically turned away from emergency rooms, and we were the last hope. And I think it was definitely tough for all of us, and I'm hoping that we learn some of the lessons and come out of this stronger.
Yeah, I remember when, when they closed us down for 2 months, and it was confusing times back then because you go back all the way to March 1st. If you started wearing a mask, people are like, well, don't wear masks. Save those for the emergency room doctor. So they, it's a lot of mixed signaling. First, they shamed you for wearing a mask, and then they shamed you later for not wearing a mask. But I remember talking to Steve Thorne and trying to support him because he's like, if they're going to shut down all the dental offices, they're all going to show up at the emergency room. And it was just crazy. And it's like, my gosh, after dentistry went through HIV AIDS from 79 on, I mean, we took infection control extremely serious, and it prepared us so much for this pandemic that it was kind of crazy that the dental offices had to close down because exactly, oral surgery and endodontists. And by the way, I want to tell you kids something. I don't want you to ever forget this. When you look at pay for my gosh, where is there it is right here. When you look at the specialty pay. My gosh, what is it for those guys? Right here, average net income for dentist is dental specialist is $320, general dentist is $197. Dentists who are owner operators own their own business, they make $244. Dentist employees make $147. But oral surgeons make $448, and endodontists make $307. I mean, dude, it's blood and guts, and you come out of school and you say, well, I don't like blood and guts and root canals and all. I just want to do bleaching, bonding, veneers, and Invisalign. Someone has to be a doctor, and a real doctor can pull a tooth and get you out of pain or start a root canal. And by the way, oral surgeons in Arizona, since Arizona is the only state where any licensed dentist can come here and practice, it's ground zero for DSOs. 18% of all dentists work for DSO. But I know a guy that hires oral surgeons and endodontists in Arizona, and their base pay day one out of school for an oral surgeon is $450, and versus their commission based on production, a lot of them do $750 their first year. Holy moly! And you tell me you don't want to pull a tooth. So how do you talk these kids back into endo?
Well, what we've had, I agree with you 100%. I think it's made, I'm a faculty at Loma Linda part-time, but, I've graduated almost 30 years ago. When I graduated, I did about 25 root canals. We talk to people who come to our training seminars that have left dental school with, you said, a massive debt, but having done 2 or 3 root canals. Because the first thing I asked in our seminars is, how many root canals have you done in dental school? And I was shocked that we had one doctor who'd done 1 root canal. So I think, it starts at the schools. After that, though, I think the COVID has given opportunity for a lot of doctors, myself included, to polish up and take continuing education courses. And we have training, we have our own training institute that, we can talk about now a little later. But our goal in this is to be able to allow any doctor to get a patient comfortable in 5 minutes by doing an open-end med. So we have a program for an open-end med, and then we have a course for the SMART 30-minute root canal. SMART standing for safe, measured, affordable, reliable, and tested. And we're doing these courses, one, to help our doctors, especially during COVID, but to fill this massive gap that exists. It's not acceptable for a patient to arrive at a dental office and to be told, take these medications and leave my office. I don't think that's acceptable. We got to be able to take care of them. And we have specific courses that doctors can take and they can put into practice the following day, the Monday they leave our courses here.
We have virtual now too. We have virtual. So we have the training courses here at the Training Institute, which is what's behind us right now. We have 14 simulation stations and 3 operatories. We have live cases, live patients. We partner with a charitable organization called the Less Than Act Clinic. We do free dentistry for them, surgical dentistry. And so those patients come in and we do charity days for them. But then when we run a course, we can actually access those patients and demonstrate live cases. But we have a virtual version now. We can send the dentist everything they need, including extracted teeth, to do the course. remotely in their home or in their office. If they're at home, we can send them a nomad and a sensor, and we can walk them through the curricula. And then we'll have an endodontist, instructor debrief their case, look at their post-op results. How long did it take them to get it done? What were their challenges? And we can have them, a couple sets of teeth in there so they can do it a couple times. So they get kind of a virtual hands-on experience as well. It includes a mannequin head. It includes all the instrumentation, the hand pieces, the files. It comes in a little kit by FedEx. You put it back in the kit, FedEx it back. So because of COVID, we have a virtual version of this now, and then we also have it in our training center.
And what is the website? I got so many websites for you guys. Which website is your training center? Is it CDS Dental?
No, it's www. C as in Charlie, T as in Tom, I as in Ivy, dental.com, ctidental.com. If they go on there, there's a list of all of our courses, and we'll be, they can look and see when the courses are available, and also the virtual courses. And then we're adding curricula to that. Obviously COVID kind of put us behind a little bit. We actually launched the center in 2020. So we're hoping 2021 we can add additional courses.
So it's ctiworkplace.com.
No, CTI Dental. Oh, sorry, .org. My mistake, .org. I always screw that up. It's ctidental.org.
Your ponytail's too tight. You need to let some...
Exactly, I need to loosen up that bun.
Yeah, Howard, if you, I'd just like to show you.
Okay, there it is. Yeah, there it is, ctidental.org.
I'm into gadgets and boxes, but we're very proud of this. This is what gets sent to you, for our virtual hands-on courses. So let me open it up for you.
If you're on iTunes listening to the audio, switch over to YouTube. Our channel's YouTube, Dental Town Magazine. And thank you for the 1 million views. We passed 1 million views on YouTube. That is just so great. Thanks. But switch over to YouTube. He's going to open up, what does it say, Cornerstone Group? First, before you introduce that, tell us what the Cornerstone Group is. It says right on the package, Cornerstone Group. What is Cornerstone?
That's our affiliate group, and let me show you the box. It comprises our different groups. We have Cornerstone Dental Specialties, which is our service company. We have the CTI Dental that we talked about, which is our training center. And we have a Cornerstone Specialty Products, where we develop products that help the endodontist and general dentists make the whole endodontic process easier. Don't forget, as a group, we've done probably over 1 million root canals. So we know a thing or two about root canals.
Wow, that is amazing.
Let me just quickly show you something, because we're very proud of this. I know during COVID, a lot of doctors, we have 14 workstations here at the center, but a lot of times the doctors, they don't want to travel. So we run live courses, and we have the whole mannequin. We have the mannequin head in the box. We have the typodont with real extracted teeth set in this. This gets mounted for the doctor in their home or their office. We have a, handpiece. We actually send you a little camera that gets connected to your laptop, so we can actually critique the cases that you're doing right from the comfort of your home. And then obviously, a handpiece. And then what we're really proud of is this disposable endo kit. Again, we've developed everything in-house, but this kind of allows you to do the root canal process.
He's got you.
Let me get this one here. Oh, great, thank you. This is our disposable kit, and it has everything you need, including, anesthesia, intraosseous anesthesia, which, I have a patent on a product for that. But any time of, the patient has to be comfortable. During COVID, we got to make sure our patients are completely numb. We have a little device, we've created called a vacuum clamp, especially with COVID. It's a disposable clamp that goes around the tooth, and it's connected to your suction. So it kind of reduces the air spray, which I think is very topical during COVID. Then we have everything you need for the root canal. We have our own endodontic files that work with our handpiece, gutta percha, obviously irrigation. So everything you need to kind of take care of either the patient or in this case, our kid. And then we have a little demonstrator up here. It kind of goes over the procedure, the root canal procedure. But the great thing is once a month, we have a live stream course. So the doctors can be interactive and they can partake and improve their endodontic skills in any way from open and medicating to doing a 30-minute smart root canal from the comfort of their home or their office.
You just said that to do a root canal in 30 minutes?
Yes.
You mean in the course or 30 minutes on a live patient molar root canal?
Well, we do the live demo, it's like, I think we have a live demonstration with our senior doctors doing a molar root canal in 30 minutes, 4 canals with using our technology.
So you're saying it's possible to do a high quality 4 canal molar endo start to finish in 30 minutes?
Yes.
Holy moly, I must be slow or have a head injury. Hey, I got to tell you something about that endo. When I got out of school in 87, endodontists were making as much money as oral surgeons because they were doing 8 to 9 molars a day. And then they fell in love with a microscope, and that slowed them down so much they dropped to 4 to 5 molars a day, and that's why you see the oral surgeons up at 448 and endodontists down to 307. A lot of people think that that microscope actually cost general dentist or endodontists about 150 grand a year. What are your thoughts on that? And then you're saying that you can do a molar in 30 minutes. I mean that's 1980 speed endo.
Yeah, well, I think in terms of innovations in endodontics, I think the microscope and enhanced magnification was critical. In the 90s, in 95, 94, I think we introduced the microscope at Loma Linda University. So I think it's critical to use some form of enhanced magnification. Now, most endodontists use microscopes. We have loops now that go up to 8 to 10 times magnification. But if you're going to do any type of molar, whether it's upper or lower, there's a high probability of an MB2 mid-mesial in the lowers, 2 distal canals. So you have to be, you have to have the right armamentarium. But if you have if the case selection is critical, if I get a tough tooth on a wisdom tooth with a separated instrument, it still takes me, probably 3-4 hours, maybe a couple of visits to take care of that. But if we have an average molar that's been open and medicated by the referring doctor, so the patient is comfortable, diagnosis has been done, anesthesia is made easier, it's possible to do that. And I think, now the new innovation or I don't think it's new, but, really for us is kind of this kind of convergence of digital dentistry and, enhanced image, whether it's cone beam with software to really demonstrate to the patient, live case where there is a problem or not. And with Tom's work and a lot of dentists, this kind of convergence of the oral systemic health. I went to dental school in England in the 80s. So a nice lesion was called, everything with a lesion in the mouth was called a beauty spot or a artifact. Those things don't exist. That's an active infection in your jawbone. It's causing systemic effects, and you need to take care of it. And the only way to take care of it is either extracting the tooth, which is what you said, or doing a root canal or endodontic surgery. So, I think the next wave for all of dentistry is this kind of digital imaging. And as a profession, there's been a lot of studies, dentists can go to a patient can go to 2-3 different dentists and get 4 different treatment plans. So to build up trust, especially, there's nothing better than a live picture or a 3D image of the tooth with problems, and with artificial intelligence and big data, we're going to get to a point where it's going to be definitive. You either have an infection and a lesion or you don't. And I think that's going to show that in reality, endodontics may be underdiagnosed, not overdiagnosed.
And kids, what he's talking about is long before you were even a dream in your parents' eyes, back in 1997. I know most dental school graduates weren't even born. But anyway, the Reader's Digest came out with an article, said, "How honest are dentists?" And it was a blow up in dentistry. Pulitzer Prize winning William Eckenberg, Reader's Digest, "How Dentists Rip Us Off." And this guy was a legend. And basically, he took study models in FMX and he went to 30 different dentists and got 30 different treatment plans. And everybody's like, what the hell? And then the National Institute of Dental Research thought, okay, we know that Eckenberg's a Pulitzer Prize winning journalist. Reader's Digest is a huge footprint in American history, and he got his Pulitzer Prize on the 3 Mile Island write-up. So they said, maybe there's something to this. So they said, we're going to redo the study, but we're going to do it to 100 dentists. And only 2 treatment plans were the same, and that was the 2 guys that said you don't need anything. And then treatment plan 3 to 90 to 100 went from like $100 to $30,000. And so, and I see that. I mean, when you're at a continuing education class, someone will hold up an x-ray and I mean, it's amazing. I don't even know how DSOs do it. Tom, you were with Steve Thorne and Pacific Dental for 10 years. How similar do you think now they're like 800 locations, 1,000 docs. How consistent are their treatment plans? And do you think AI will help them treatment plan more succinctly and evidence-based and intelligently?
Yeah, I think that AI is going to have a major impact in big data, but some of the larger DSOs that, it's kind of a cultural thing, but it's in Pacific Dental specifically, there's a lot of internal review, but not too dissimilar to a hospital. So I worked in healthcare for a long time, and most hospitals have a review board, or they have a group of doctors that kind of look at different things, different trends, different items. And it's not a punitive type of a situation. It's more of a collaborative and a communicative style that says, look, did you think about it this way, or why did you decide to do this versus that? And so there's a lot of coaching, education, training that goes around trying to make sure that the diagnosis that's made is accurate, number one. Number two, the treatment plan is appropriate for that adheres to the standards of the dental community at large, and the data and the research that backs that up. So that's how we did it at Pacific. I can't speak to other DSOs, but it is one of the distinct advantages of DSOs. There is some kind of quality check that does exist. And somebody kind of helping younger dentists and dentists that may not have as much experience kind of look at things in a different way.
But you were talking about just a second ago. You were talking about new technology and in endo, and the new technology. Of course, I know my homies because I can see their surfing behavior on Dental Town. And when something starts costing a lot of money, they'll go. The people who go to Dental Town every day, they go to Today's Active Topics and kind of read it like a newspaper, like what's everybody talking about. But when someone does a specific search and then stays on for 3 hours, they're going to buy a $100,000 CBCT, a CAD cam, and an endo. It's that new Son Endo. And everybody's like, how much is a Son Endo going for these days with Bijarn Bergheim?
Well, I think you're referring to the Gentle Wave.
Yeah, made by Son Endo.
Yes, correct. Well, I think there's a great attribute. To answer your question, is about $85,000, I believe, between $70,000 to $80,000. And I believe the disposable costs are from, more than $50 per case. But, the principles, that's what I'd like, to comment on a little bit for your viewers. I think it's a great product. A lot of endodontists are using it. But there's nothing, the technology, we call it activated irrigation. There's nothing new about activated irrigation, and there's different forms of it. We have you can get endovac, which is a negative pressure for irrigation. There's sonic forms of irrigation. Endoactivator is one made by Dentsply. I think costs $150. Vista makes a product, handheld ultrasonic device. So there's no doubt that, especially for cases that involve infected cases and retreatments, you should have some form of activation with the sodium hypochlorite or irrigation that you're using. So, and if you don't have any of those, you can fill the whole root canal chamber with sodium hypochlorite, or some of the new sodium hypochlorites with added surfactant that adhere to the dentinal walls better, and use your ultrasonic unit you do for scaling. That'll create some acoustic waves in the tooth.
Okay, but just to be clear, I'm going to hold your feet to the fire. It's 85 grand, dude. Buy it. You know, should a dentist who's doing 7 molars a month spend 85,000 on Sonendo's Gentle Wave multi-sonic ultra cleaning technology, or would you take a pass?
I think if we don't use it, so
you don't use it.
I don't want to, get on the side because I know the technology is good,
Yeah.
but we don't use it.
There's two things. I mean, number one, the Sonendo's Gentle Wave, you're not really going to use it till you've already worked it up to at least a 25 or more, right?
Yeah.
And so it's going to clean out more. But the most of the debris left in the tooth is a missed canal. My homies, and myself included, have a hard time finding the MB2. If I found all the canals and got them all worked up to a 25, the last thing I'm thinking is, oh, I need an $85,000 extra ultrasonic cleaner. I need an $85,000 thing to show me where the damn canals are.
No, I agree. Let me just say a couple of things because, I think it's a very important point. This concept of a vital tooth versus a necrotic tooth, and how some endodontists, if in doubt right now, I've become a little more aggressive. If in doubt, I do the root canal, because all the research shows that if the tooth is vital in the state of irreversible pulpitis, and the AAE, the American Association of Endodontics, has a classification for asymptomatic irreversible pulpitis. When there's no lesion on the tooth and the tooth is vital, the body is much more forgiving. I'm not suggesting any shortcuts, but if the root canal is a little shorter, or maybe the irrigation is not ideal, the body may heal because you're working in a sterile environment. When you have a lesion on the tooth, or the tooth is necrotic, then all the research is compelling that the success rate is anywhere from 5 to 10% less when you have a tooth with a lesion on it. And you have to be much, much more, you have to be 100% precise now. You can't feel a little short. You can't miss any canal or anatomy because the whole tooth is infected. But coming back to your question, I agree with you, 100%. That's it's a large investment to make. And, unless you're doing a certain number of root canals. And to be honest with you, the data is not compelling. There's no large study that shows using Gentle Wave you're going to get better clinical results and outcomes than using some other form of activation when it comes to irrigation.
And another problem we have is the fact that since dentists don't get along with their value chain like all the other industries, the whole value chain works together. But you have the dentist and the insurance people. They just live on two planets and they don't talk. When I talk to the chief economist of the ADA, he's on the same city as the head of Delta. He doesn't have access to any of their data. When I drink with them at a bar, I spoke in Florida to all the dental insurance dentists and evaluators and all that stuff, and they were showing me amazing stuff, but they wouldn't let me post any of it on Dental Town or the magazine. But they convinced me that when an endodontist does a molar endo, in 5 years, 5% of the teeth are extracted. They don't want to debate if it healed in the periapical. It just, is the tooth still there or not? Endodontists do molars in 5 years, 5% are gone. And when general dentists do the molars in 5 years, 10% are gone. So the question is, back to Sonendo, is why is that? Why do endodontists do a molar and root canal and it's extracted 5 years later? Is it because they didn't get it all cleaned and shaped? I would venture to guess that it's probably a fracture. It probably wasn't restorable to the first place. But you're smarter than me on all things endo. What would you say?
Well, I agree with 100%. I think that was the Marquette study with Delta that looked at almost 500,000 teeth. And they found that exactly as you said,
Who Delta did that?
Yeah, Delta and Marquette University did that study with 500,000 teeth. But
I didn't ever see that. Can you send that to me?
Of course, of course.
Oh
They
my
fit teeth
God.
at different times. And as you said, after 10 years, I think after 1 year, if my memory serves right, about 96% of teeth were good. After 10 years, as you said, it was about 90% with a 5% delta, which was significantly, it was statistically significant at 5%. But coming to your point, there's a lot of different factors. The implantologist, and Tom is going to kill me on this because, because we have these discussions about endodontics versus implants. The endodontists have figured this out very easily. In a lot of their studies, they eliminate smokers, they eliminate bruxers, they eliminate people with diabetes, they eliminate people with type 4 bone, and they show result. They eliminate people with large periodontal disease, and then they look at survival versus success. As endodontists, I think we shot ourselves in the foot in the 60s, studies out of Scandinavia. We had very high criteria, reestablishment of lamina dura to consider it success. So there are a lot of other factors as well, including occlusion, coronal leakage, restoration, that can impact endodontic success as well. But I would ask the implantologists, because they're masters at doing special studies with a lot of criteria. And I think we're coming back to a happy medium now. To be honest with you, I've been a dentist 30 years. Looking back 25 years as an endodontist, probably looking back in my own history, there's certain teeth that I didn't need to retreat 2 times and then do a surgery on. I should have just extracted them and gone on implants. And at the same time, there's teeth now, healthy teeth, that are being pulled to place an implant. When anybody's placed any implants knows that there's a lot of complications that are associated with those as well. So I think it's coming back to a happy medium now where hopefully we put the patient's interest first, and I place myself as the patient sitting there. What would I get in my own mouth? And I think the success with both of them is pretty good. It's over 90%, 5 years, which I think is a good success rate for your tooth that's in a dynamic environment, going through abuse constantly.
Wow, that was profound. But one of the things that I still am concerned about with the kids, it's not the fact that they especially with COVID, that they didn't get much clinical experience, but when they're on Dental Town and they're asking about a clinical diagnosis of the endo history. I mean, medical dental history, recent treatment drugs, chief complaint, how long symptoms, duration of pain, located, blah, blah, blah. But on just clinical, I don't do pulp test. No, we don't have an EPT at our clinic. How would you test it for heat, percussion? I mean, some of them don't even have a tooth sleuth. And you're sitting there thinking, you work in a clinic and they don't have a pulp tester, an electric pulp tester. You don't have a tooth sleuth. I mean, it concerns me that they're not doing what I consider to be the basics back in the day. Do you see any of that or not really?
Yeah, I agree. I couldn't agree. I think on one extreme, we have, cone beams and, gentle wave. On the other extreme, Howard, our tests are prehistoric. We need a little hammer for percussion, tooth sleuth, maybe for cusp coverage. We use ice and heat, which is a simple endo ice. Endo ice is probably $10 for a little bottle. And then an electric pulp tester for about $100. So I'm not advocating spending hundreds of thousands of dollars on a cone beam and gentle wave, and we have microscopes and other things. But to get the preliminary tools that can help you determine to take you from a dental mechanic to a dental doctor of dentistry, which is strong diagnostic skills, to come up with a apical diagnosis and a pulpal diagnosis, is probably $100 worth of tools. It's not that much, but we have to, because when I served at the AAE and peer review, it doesn't matter how good the root canal looks, whether you found 4 canals or 5 canals, we have to have a clear diagnosis. We have to have a pulpal diagnosis, which really, as you correctly said, involves pulp testing, basically endo ice and an electric pulp test. And then the periapical diagnosis, which basically involves looking at a radiograph carefully, looking at the lamina dura, and using the back of the mirror basically to hit the tooth for percussion, doing a palpation test with your finger, and then if you suspect cracks or other things, using a tooth sleuth or a Q-tip. But those are simple tests, and they for about $100. So I can blame you if you don't spend $100,000 to buy the latest cone beam. But at $100, I think most dentists should be doing these routinely, because we have to get to a pulpal and an apical diagnosis before we pick up the burr and we cause irreversible damage to the tooth with our burr, basically.
And what was the website of your clinical dentist, mobile dentist, I believe, or the specialty group?
Yeah, cdsdental.com.
cdsdental.com.
Yes, that's for Cornerstone Dental Specialty, cdsdental.com.
Oh, okay. So that's the CDS site. So talk about that. So what is that? It's Cornerstone Dental Specialty set out over 22 years ago to answer these questions. But tell us what you do.
So Cornerstone Dental Specialties is probably the largest group of endodontists in North America. We have 40 endodontists that service 13 states and roughly 400 locations. We do about 450 to 500 days of endo a month, or about 3,500 cases a month. And we primarily service the DSO space in that model. And instead of a patient being referred to another brick and mortar location, we come to the location and take care of the dental needs in that location. So patient A gets diagnosed on Wednesday, we show up the next Wednesday, they're open and medicated, they're ready to go. We take care of their root canal. And if they have chairside milling, then it can actually crown that tooth many times that same day. So it's a massive reduction for visits for the patient, much more convenient for the patient. The patient knows that we're going to take the insurance that's there at the office because we're contracted with that. So there's a lot of sticky mess that, I always tell people a lot of bad things can happen when you hand a patient a business card and a referral slip. This allows us to kind of more control and make sure that patient does get treated, that treatment is continued and finalized. And it's all done under the same roof of the general dentist that the patient has the strongest relationship with. And so that's the Cornerstone model. We're starting to open up a model like that in the non-DSO space. That's the SDDS 360. And that is exactly the same model with two major exceptions. One, in the model of the general dentist, we're gonna do all the billing, we're gonna take care of all the credentialing, everything, and we're gonna still monetize that visit for the general dentist. But most importantly, we're gonna show up in that practice with a digital design studio that's gonna have a cone beam scanner, chairside milling machine, intraoral scanner, 3D printer, facial scanner, and all the tools in our armamentarium microscope that we need to complete the cases that day. We're going to bring that into the office, use one or two operatories, treat their patients, and then we leave and come back on a rotating basis. So kind of taking what we've learned in 17 years in the DSO space and doing a million root canals this way, and kind of starting to approach now the private practice. And you brought something up earlier, which is we decided purposely to target this in the more rural or outer suburbia markets where access to care to an endodontist is limited. There's only 5,700 endodontists roughly in the US to service 350 million, probably go up to 375, 400 million people. And in the areas where the flyover states and the non-bi-coastal communities are massively underserved, when you look at the Kaiser Permanente family data, they're massively underserved in the Midwestern states. So that's going to be our initial focus, to increase access to care and try to bring this model that we've honed over 17 years to a much broader audience.
So the general dental is going to be the your website, Surgical DDS 360. That's the name of the company?
Correct.
So Surgical Deal is going to do what you're doing with Cornerstone Dental Specialties for DSOs. Surgical DDS 360 is going to be doing that for general dental office to be obviously the more convenient, etc. So what states are you doing this right now in Cornerstone Dental Specialties for DSOs?
It's 13, it's probably 11, 13 states. It's, we're mostly in the Southwest. So you think California, Arizona, Oregon, Washington, Colorado, and each one of these states has, different levels of penetration. We're in Tennessee, we're in Virginia, we are in Minnesota. Trying to go through. We're in Nevada. So yeah, going through those states in my mind right now. But I kind of think of more the Sun Belt states, kind of going up the West Coast, and then starting to encroach on the East Coast, Southeast, and East Coast. And as far as the new model, we're focused initially on Tennessee and Missouri. That's where we think some of the greatest need is. So we're starting our new platform and that platform we're hoping to extend down the road. As you can imagine, if we're going to show up to do endo, we could potentially show up and do larger implant cases with an oral surgeon or an implantologist. We can show up and do oral surgery for wisdom teeth, perio surgery. I mean, we're not going to get involved with some of the other specialties like pedo and ortho. That's not going to work. But for the surgical specialties where it's 1 or 2 visits, we think that we can extend this platform in the future to other specialties.
Well, pediatric dentistry and orthodontics is doing best together. That 1 + 1 is 3. You take your kid into a pediatric dentist. Every mom says, "Does Billy need ortho?" And those two are coming together, no doubt. Clear Choice showed us that when you take the implant surgeon, the prosthodontist to restore it, and the lab tech, that's 1 + 1 + 1. How that equals 5 because that company's been sold 5 times. They're doing, they're making money. They're making so damn much money they can never resist selling it to the next highest bidder. But I think oral surgery and endo go together. You said it in the beginning. Oral surgeons and endodontists are the emergency room doctors for dentistry. Yeah. And that's where the money is because, if I went in, you got to convince me to get bleaching bonding veneers. I mean, if I went in your office and you said, "Howard, you look so much more handsome with veneers," I'd probably laugh so hard my molars would fall out. But when you're in pain, you're begging the doctor to do it. But kids, here's the other thing you got to figure out. If you're a cynical bastard like me, money's the answer. What's the question? The insurance companies are driving this schism because they're at the value chain too. They're paying for this stuff, and they know when they pay an endodontist to do it, it's more likely to be done once instead of twice. The state boards. Anytime a general dentist has a root canal fail, they always go show it to the endodontist, and then they start asking these vague questions like, well, was this done to the standard of care, which there's really no definition to. What is the standard of care? That's about as vague as, it's too vague. But here's the deal. When I do a molar endo and they give me $750 and I pay my associates 25%, well, they might pay an endodontist $1,300 to do it. And then the endodontist comes in, and around here in Arizona, they're asking for 40 to 50% of the fee. So then you're looking at the math. Well, what's 50% of $1,300 versus 25% of $700? And you start looking at it, and it's like, my gosh, I actually will make more money if the endodontist does it. And you guys are saying that you're going to do the insurance billing and collection for those fees. Is that just because you don't have faith in the general dentist doing it? Or is it for more control? And what software are you using?
We've landed on Planet DDS as our platform. And it really is partially because it's a pretty complicated process to get everybody credentialed at locations and making sure that the insurance is billed out properly and everything. So like I said, we just feel, and there's some control too, to be transparent. But I think it's more or less in these more rural markets where they're not used to, working this way. We found that when we did our research, the stress level of bringing a specialist in went down a little bit for the front desk, for the front office, the staff, the team. We kind of do a turnkey solution. For a day or two a month, we're literally like a virtual brick and mortar practice inside their practice. So it becomes very hassle-free from a referral standpoint, very hassle-free for the staff, hassle-free for the dentist, and they still get to monetize it, unlike they can when they just send it out to a brick and mortar.
So you chose Planet DDS for your software,
Yes.
and that's the leading top-rated cloud-based practice management solution. I'll come back to that in 1 second, but I want to know the other one is that my gosh, didn't Son Endo Gary Carr is a really famous endodontist out there in San Diego. He's the only person who ever kicked me out of a CE course, me and Mike Totola, because it was limited to endodontists only.
Yeah, you're talking about TDO.
Yeah, and he owned TDO, the digital software, where so many of my friends, and like John Lee's out in California, he loves that TDO, but they sold that to Son Endo.
That's correct.
If they didn't sell that to Son Endo, would you have considered using TDO software since you're endodontist? And what percent of your business is just endo versus the other specialties?
Oh, right now we're 100. We had a little bit of oral surgery, but basically we're 100% right now endo. The decision for Planet DDS was predicated on. Now we didn't do a ton of investigation in TDO, but the Planet DDS, the fact that it was cloud-based, the fact that it had very large market share, strong support team, and they could assist us with the back of the house. I mean, the front of the house stuff like the billing, the credentialing, the benefits coordinating. They have a lot of automation built into the system because obviously we're mobile, so we need a lot of high-end technical support. It's not just about the record, not just about the chart and how we manage our radiographs and some of the nuances that are in some of these specialty softwares. It's more about kind of the complete continuum of care. And as I mentioned, our purposeful intent is to eventually layer in other services into our platform because once we build trust with these clients, we're pretty confident that if we bring in a competent implantologist or oral surgeon, and they do have a need for more extreme cases and implants, that they would choose us as their partner. So it was a combination of lots of things that landed us on Planet DDS.
And that was with Eric Gaisecki. Is that how you say his name, Gary? Eric Gaisecki, CEO of Planet DDS?
Yeah, Eric, yes.
Yeah, and I butchered his name. Yeah, I had him on the show, number 758, amazing man. But it sounds like the cloud was the big feature for you. Would that be safe to say?
Yeah, I would say that was probably the number one leading decision factor.
So the general dentist, the number one new go-to is Open Dental. So I'm sure Eric would love it if you gave him a plug for Planet DDS. But why did you like Planet DDS? And I was with SoftDent for 30 years. That was the biggest beast in the room, owned by Kodak and back in the day. But why do you like? What would your plug be for Planet DDS over like Open Dental? Did you consider Open Dental?
We did not. I don't believe that was not one of the ones in our queue. I would say it was what we felt was the comfort of their support. We got a lot of time with their senior leadership team, including their technical team. So understanding they had a lot of people there for a long time, and they really understood dentistry and their support. And then I think they're again back to the kind of the cradle to grave for us was really important. Someone that we could outsource a lot of this stuff that maybe dentists don't need to outsource it. They've got really great staff. They've been with them for a long time. They're fine with doing certain aspects of that front office work. But anything we could take off of our plate to focus on our core competency, which is our service delivery. That was probably the biggest factor. But they're local. That didn't hurt. The fact that they're local, they're down the street from us.
Yeah,
I've used it as well extensively. We provided endodontic services at Facebook, so it worked very well in our hand. I'm sure there's other softwares that do a great job as well. I just want to say one thing though. At this kind of continuing my career, I had a brick and mortar endodontic practice for coming up to 14 years. I think one of the advantages our group, especially with the training that we provide, we try to build a deep relationship with the general dentist that we go to. So whether it's access to our courses, we specifically work with our dentists. We actually give them one of our open and med kits So any patient that comes to the office can be taken care of by the dentist. That includes hands-on courses. We offer over 16 hours of CE. But I think it's
which site is the 16 hours of CE?
If you go to ctidental.org.
Okay. You guys need one website just to have all your websites listed. You can just say, go to this website, and so which one is that? SDDS 360 is it CE, or which one?
Yeah, we'll probably link them. If we get,
They are linked.
We'll link all of them to the CE. That's a good thing. So you go to any of these, but the Cornerstone Training Institute, where we're sitting in right now, ctidental.org. But I understand it's kind of confusing. But when we go to the offices, we offer hands-on courses. We work with our general dentist partners to make sure, because don't forget, Howard, we're in the office maybe one time or two times a month. When the patient arrives on a Tuesday, the general dentist has to be comfortable to do the diagnosis. So we have, all the tools for diagnosis. They got to be able to do a case difficulty assessment to make sure it's something that they would do or it's something they would refer at. If it's a case that they would refer to one of our endodontists or providers, then they've got to open and medicate the tooth. So we have special kits for that, hand pieces, kits. So whatever we can do to impart information, knowledge, and develop a deep relationship that's based on a collaboration between, the specialist or the super dentist and also the owner doctor of the office.
So the continuing education is on ctsdental.org?
C as in Charlie, T as in Tom, I as in Ivy, dental.org.
Okay, there it is. Well, you know what you might want to do, if you got 16 courses, we put 400 courses on Dental Town. They've been viewed over 1 million times. And you ought to put one of those courses on Dental Town Continuing Ed, where you could introduce yourselves and then tell them for 12 more courses, go to your website.
Yeah. 16 hours is our root canal course, but I'd be happy to share our course I did for COVID. That had a lot of reviews, and we'll be glad to share content.
Oh my God, the smart 30-minute root canal endodontic course, 14 CE credit. So that's one course. It's a 14-hour course.
Yes.
Oh, okay, and that's free?
No, that's not free.
How much is that one?
Yeah, I can, as I said, we have a COVID course that I'll make available at no cost. For the doctors that we affiliate with and we work with, that's that's all included, because our endodontists are, clinicians. A lot of them are instructors. We work one-on-one, so they'll get those courses at free when they join. But for individual doctors who want to do the hands-on course outside of our group, it's a paid course.
And how much is that paid course?
I think it's a 2-day course, and it runs about $19.99. But it's a hands-on course, and it includes a patient component as well. And you get probably $300-400 worth of supplies and kits to take with you.
Nice, man. That is amazing. So you just opened up a huge can of worms, COVID-19. I don't know if you guys heard about that yet, but there's this virus thing going around, and I got vaccinated January 5th, my first shot, and then 21 days later will be January 26th, my second shot. And the number one thing people are emailing me saying, they want me to ask my guest, would you take the vaccine today, right now?
This is mine.
Oh my gosh, he did it. He got jabbed.
I got jabbed.
And I go get mine this afternoon.
Your first one or second one?
First one.
First one, yeah. I had more hair than you and a longer ponytail before I got the vaccine. So good luck with that, Thomas. I hope you saw that ponytail a week from now. So how did COVID change what you do? How did COVID change endodontics for the year 2020? And is it still having any impact in 2021?
Yeah, I think you hit it on the head with a lot of the things that you mentioned. I think, as I said, for oral surgeons and endodontists, it didn't have much of an impact. You know, there were several months, I think overall we're down, but it didn't have the impact that it had on some other industries that are devastated. With that said, I think because I went through the HIV, crisis as well when it occurred. So dentists are, we're well prepared. We're already taking universal precautions when we're seeing patients. So I think the doctors that opened and took care of emergency patients, they managed to build even deeper relationships. I do think it has some impact that I've seen with my own patients. Patients want to come. They don't want to keep going to different locations. They want to just come to one location and get the work done and leave. That takes the pressure off of PPE, masks, gloves, and other things. So having the patient, this is one of the things that led to us developing some of our protocols for STDS 360. We go to the location, that reduces the visits for the patients. The statistics are clear. Patients don't like leaving offices. They don't like leaving their general dentist. They've got a great relationship there. So I think general dentists doing more courses, taking care of their patients, or affiliating deeper with their specialty network is probably one of the things that I see, come out of this crisis that hopefully we're going to be getting out of.
Well, I mean, let's talk. When people like when Canadians brag and they say, I went in, I had a cancer treatment and a bypass, and it didn't even cost me a nickel. Okay, so what are you saying, that we should take everything we learned in economics from gosh darn The Wealth of Nations by Adam Smith in 1776 to today and just throw it away because a Canadian says it didn't cost me anything? So now people don't show up on price. They're not. You don't have the customer. In anything in economics, all healthcare should just have a straight 10% copayment. If you're going to get a $50,000 knee replacement and you're not willing to pay $5,000, well, why should everybody down the street pick up the whole $50,000 if you're not willing to pay $5,000? There's got to be an incentive. If there's no incentive, it doesn't work. And my gosh, in dentistry, it's kind of a reverse incentive. Every dentist is a tribal monkey, so he wants to own his own house. So he builds out a whole dental office. There's 168 hours in a week, and he's open 32 hours, and so it's closed 81% of the week. And the 200 years of Adam Smith to now, we know in retail, the bigger one-stop shop won everything. 200 years ago, you had a shop house where, you lived upstairs and you had a little something about the size of your garage. And the next generation put you out of business by putting 2 garages together, and then 3, then 4. And then they maxed out in America when Walmart and Costco and all the big players said that 250,000 was too big. They started seeing people like me. I won't go to a Walmart that big. I'd rather go buy a gallon of milk at Safeway where it's reasonable. I don't want to go to, the Cardinals football stadium to buy my groceries. So their size matters. At least that's what all my girlfriends told me. So the bottom line is, if I go take my child to a pediatric dentist and I ask, does he need braces? Well, the orthodontist should be right there. If I go in there to an endodontist and they say, no, it's a cracked tooth, we shouldn't do that, well, then he should be able to pull the tooth and place an implant. Or they want one-stop shop. I was shocked the first time I lectured in Australia. I go down there about every 5 years since 1990 and do the big, I fly into Auckland, New Zealand, and do Sydney, Melbourne, Brisbane, Perth, Gold Coast. I've done that every 5 years for, 30 years. I was shocked the first time I went down there. It was so cool. It was like going back to 1950. At that time, the grocery store, you had to then go to the bread store. And then you had to go to the butcher. And then you had to go, it was like I had to go to 5 places. And I thought it was really cool because they don't even have those in America. It's all thrown under one roof. Clear Choice, another example. Put the oral surgeon, the prosthodontist, the lab tech all in one room. And then the other thing, when you look at dentistry, so there's 150,000 locations and they're all closed 80% of the time. Dentistry doesn't need to build another dental office for a decade. If you're a dentist coming out of school, you should get a damn app, and your patient calls you up and says, hey, can you clean my teeth? And he pulls up the app and says, yeah. oh, Howard's dental office is available. I meet you there in an hour. And then there'd just be a straight fee, and we have a $50 an hour room fee or something. And you come in there and do the. If I was an endodontist coming out of school, the first thing they do is they complain, well, I had $400,000 in debt at the dental school. And then I went to endo school 3 years, and now I'm $700,000 in debt. I say, okay. Stop the madness. Don't go out and buy land, building, and build another dental office. Are you out of your mind? You're going to build a dental office when 80% of operatories are closed. It's kind of like freeways. When you look at a freeway, a car needs 10 car space for every 10 miles an hour it goes. So say the average car is going 60 miles an hour, needs 6 car spaces. Freeways they're not even used 10% of the time. They're empty all night long in the middle of the night, all this stuff like that. But no one needs to build another damn dental office for 20 years, especially if you come out of school with $40,000 in student loans. 7 to 7, 7 days a week is the business model that the only 3 publicly traded dental companies on planet Earth, that is their hours. That's 1-300 Smiles and Pacific Smiles Group in Australia, and Q&M out of Singapore, which, Rick Workman was the first billionaire dentist in America, but that guy and Q&M, Raymond Ang, he's rolling that thing across China about as fast as Genghis Khan went through it, and they love it because, it's quality first world dentistry, and he has 1,300,000,000 people to roll through. That's why America's economy was so much bigger than England, just because, even today they only have 70 million and we have 320 million. Size again matters. But if I was an endodontist coming out of school, and you'd add all that debt for a land, building, buy a practice, are you out of your mind? I would pick the 5 largest practices in Phoenix, Arizona, and just go up to them and say, I'll do your endo Monday, Tuesday, Wednesday, Thursday, Friday. And everybody wins. The patient wins. Your treatment plan case acceptance wins. Dentists don't even track their treatment plan acceptance rates, but same-day dentistry is the #1 driver in treatment plan acceptance rate. When you say, yeah, you need a root canal, but here's a piece of paper, you got to call another number, go down the street, all hell breaks loose. When you say, well, we can't do it today because, our staff, we had a no-show at 10 and a no-show at 11, and you're probably thinking, why don't we do it now? But now it's lunchtime, and we're like government employees. We're entitled to a lunch, so we're all going to leave at 12 while we give you Percocet and Vicodin and antibiotics. And it's like, man, work hard and hustle. And if you're slow on endo, I always scheduled it at 11 o'clock before my noon lunch break, and at the 4 o'clock before we close at 5, so that if a 1-hour root canal went to 2 hours, I didn't care. I was ready to do it. So, don't go buying another dental office. That's crazy. And if you get out of school and your mom and dad are still alive, I'm reading studies that 38% of senior citizens in America are lonely. And that's because if you weren't subsidizing with them with Social Security with money you didn't have, they'd be living with you. And then your complaint is you can't find daycare. Why? Because grandma's being subsidized in another house. My gosh, come out of dental school, go move back in with your mom and dad. I met a dental student the other day who asked his grandma if he could move in his grandma. He said his grandma threw her arms up. She's going to have a roommate and it's her grandson. And he's getting home-cooked meals, free room and board. So incentives matter, economics matter, all this stuff matters. And I think the business model you have, when are you going to do it for me in my dental office in Phoenix, Arizona?
We'd be glad to take care of you. Phoenix is overwhelmed with endodontists, so you got plenty of endodontists up there. But
I cannot find one to come into my office 1 or 2 days a week to do the molar endo.
Well, Tom, you talked to Tom, but you almost read our business plan about space and utilization. But Tom, we'll follow up with you, and we can serve you, Howard. It'll be our pleasure to work together.
Well, so let's go back to Arizona. Arizona's #1 crowded because our Governor Ducey, who everybody sounds like he can't find any friends. But he says if you're licensed anywhere in the United States, you can come there. So, it's really hard to go get a dentist to sell their practice and take boards and move to another state. And I'm totally against that. In fact, I think all the boards, I think they're horrible, because I see the large Hispanic populations in Guadalupe that doesn't have one American dental office. And every time a Mexican trained dentist comes to Guadalupe and starts treating the poor, the board calls their mobster friends the police, and they're arrested and kidnapped and put in a cage and deported. Why? Because they were because they didn't have an Arizona license. I mean, talk about an evil racket. Healthcare never had an affordability issue until 50 states rolled out 50 state boards and didn't let any foreign trained doctors in here. And what the board should do is tell me, hey, is this guy an endodontist? I mean, he says he's a dentist, but I don't think Tom Von Sydow is a dentist. I think his friend Hamid Abedi is, but I mean, I'm the consumer. The same thing with chemotherapy agents, okay? This drug isn't approved. Well, the FDA then takes a step further and says, so we will not sell it to you. So then again, the person I bought my house from had to move to Scandinavia to get a drug invented by an American, made by an American pharmaceutical, but the FDA wouldn't let her buy it, so she had to move to Scandinavia. That just makes me so mad. If the FDA says, hey, Howie, you got a brain tumor, and we have not approved this drug. And it's like, well, my only other option is death. Why don't you move me ahead of the mice and rats and cockroaches and let me try it? I mean, what ruined history is when a bunch of rich people that have lots of options, they spend all their time taking away the one option for the poor guy. If I want to go to a dentist in Guadalupe who got his dental degree in Mexico City, I have the right. Who the hell is the state board telling me I don't have the right to see it? And then furthermore, I go to these guys and say, so you're saying no health care is better than none? Are you out of your mind? And they go, well, what if they did something really bad it's like, he's a trained dentist. G.V. Black didn't go to dental school. I mean, they were apprentices back then. Don't pull my string. You probably pulled my string on purpose, didn't you? You just wanted to see me blow a blood vessel.
COVID may have I'm hoping it'll have a positive impact, because, forget about dentistry. Medicine, when we had the crisis in New York, it was difficult. Doctors were volunteering, but this whole thing about the state boards, a lot of the barriers should come down. If you go to an, ADA accredited program, I agree with you 100%. You shouldn't have to go through 5 other loops, especially when it comes to taking care of patients.
And the ADA just got, they got marginalized in Texas when that implantologist was advertising as a specialist. And the State Board of Texas took it right to court and said, that's not a specialty. The ADA does not recognize it. And the judge said the ADA is a membership organization. What the hell does that have to do with this guy? First and foremost, is he lying? And they go, no, he has a diplomat in the International Congress for Implantology, and all he does is implants. And the judge's like, well, what's the problem? Oh, well, our membership organization doesn't want him to say he's a specialist. Well, they don't care, and now you can do, in fact, a lot of the endodontists, some of the greats, I don't want to butcher the names wrong. I think Ben Johnson, it was either Ben Johnson or it was John McSpadden who just passed away. What a great loss in endo. I love that guy so much. He was just a great man. But back then, they didn't go to endo. I don't think McSpadden went to endo program, did he?
No, his grandfather then.
Yeah, he was grandfathered in. So what did they do? He was practicing in Chattanooga, and all of his friends, he's telling them all about this exciting endo, and his friends told him like they tell him today, I hate endo, I'm not going to do it. And he said, well, I'll tell you what, I'll have my practice limited to endo, and when you send the patient here, I'm not going to do the crown and cleaning and steal your patient. I'm not going to do that. So just, let them practice limited. If I was graduating in COVID-19 and And I was thinking, and I didn't get accepted in endo school. That's another thing that's funny. When people don't get accepted in endo school, they just throw in the towel. You know how many people I know go to Dominican Republic, Belize, somewhere down in Central South America, get their endo training, come back up here and file the board, and it's all good. But I would sit there and I would go find the urbans are very competitive everywhere, and the rural is flyover. I mean, I just did a webinar with the Rear Admiral Timothy Ricks, and I posted that on Dental Town, and he was talking about, oh my gosh, it was amazing. That was a podcast I released a couple days ago, but he calls it Dental Deserts. 60 million people, 6,487 dental health professional shortage areas determined by the HPSA. That's a health, I don't even know what it stands for anymore, Health Resources and Services Administration. Only 29.28% of their dental needs are met. 10,716 practitioners needed to remove the HPSA designation. Well, my God, I could fill all those just from Mexico and India tomorrow morning at 8 o'clock. But it's the state boards that's keeping those people. So that's what the government always does for 5,000 years. They take a baseball bat and break your legs, and then they offer to help you buy a wheelchair. And it's like, when you go to the government for help, you just have never read a history book and don't know that they first break it and then you ask the person that breaks it for help. So this is the state boards. I would like everybody at the Arizona State Boards of Dental Examiners to go spend the night in Guadalupe every night and listen to the crying children with toothaches while they say, well, no, we're not letting any Mexican dentists in here. So, please don't ever bring up the government when you're talking to me on my podcast because it kind of ruins the whole show for me. But anyway, so I want to go back to, gosh, we went over an hour. Do you guys got to go? Can I go into any overtime with you, or how are you guys looking for overtime?
All yours are.
You're all mine. Oh my gosh. Well, go back. I want you to go back. CBCT. That's a great one. It's another $140,000 piece of equipment. Is it standard of care? I mean, the number one cause of root canal failure is you didn't get it all cleaned out, and you didn't get it all cleaned out because you missed an entire canal. So do you think a CBCT helps you find that fourth canal? And is that standard of care?
Yeah, I think it definitely helps in certain situations. I personally don't think it's the standard of care. You don't need a CBCT if you're doing a number 8 anterior tooth. You got the concept of ALARA as low as reasonably achievable. The radiation. Don't forget, especially on children, depending on the type of field of view you have. If you have a full field of view, you may get up to 300 microsieverts of radiation. So you got to weigh that up. So I think it's a delicate discussion. The AAE had a position paper in 2015 about that. So you got to weigh things up. I think if you're doing a retreatment or you're a surgical case with anatomical features that are close by, I would definitely recommend a cone beam. But for a standard case, where a regular periapical radiograph is giving you about 2 to 4 microsieverts of radiation, you get a couple of angled radiographs on an average tooth, and your dental anatomy, and you're using some form of magnification. I think that should be, in my opinion, that should be fine. But in complicated cases, retreatment, surgeries, I definitely think it's it's very useful.
So I just want to say one thing, kids, and again, I'm not an endodontist. I never lectured on clinical dentistry because I think endo should be taught by endodontists, oral surgeons by oral surgery by oral surgeons. I mean, I think the 12 specialties should talk about, if you want to learn something about oral surgery, endo, perio, pediatric dentistry, orthodontics, prosthodontics, dental anesthesia, oral facial pain, oral med, oral path, oral radiology, dental public health. Why are you talking to me? I mean, they're specialists in that stuff. But here's what I learned after 32 years of doing molar endo, and this is my common sense approach. I can't do endo through a PFM or an MOD amalgam. I first take everything off. The tooth died. There's bacteria getting in there from somewhere, and it's not coming from their kidney up to the apex of the root. It's coming from their mouth down. So the first thing I do is I take everything out. And you say, oh, we just put that crown on there. Well, then if you put it on the crown, you can take off the crown, throw it away. It's dead. The tooth died. It's done. Because when you're going through cusp and you're trying to figure out your working length, and one's measured on a cusp tip, and one's on a valley, and one's on a furca, and you got 4 files, and you're trying to remember 21, 19, 17. No. Take out the whole restoration, take off the crown, and pack your cord, and first determine that this tooth is restorable. Then when you go to access the pulp, you need a right angle burr. You need something like a 557, no round burr stuff, because when you got a right angle geometry, when you fall through the roof, you feel that you fell in there. And rule number 1, don't touch the floor. I'm never going to find that MB2 if you start screwing up the whole damn floor. So now I got the tooth prepped for my final restoration. I opened up, I don't care how big the access hole is, because I'm going to stick a crown on this thing when I'm done. And then I didn't touch the floor. That's how I do molar endo. I mean, when I see these guys doing a molar endo through a PFM and they put a final amalgam filling and it looks like the size of a BB, it's like, what is going on? So that's what I do. So feel free. You're an amazing endodontist. Feel free to tell me that was the worst endo lecture you ever heard in your life. Was my 5-minute rant on endo.
No, I think, you were dead on. I think we got to remove, there's this concept of ninja access preparation, which I'm not an advocate of, because that really reduces the irrigation. Don't forget, it's, the instrumentation is great, but you really need the irrigation. Is cleaning and shaping. The cleaning gets done by irrigants. So you need this minimum amount of space to get your irrigants in there and make sure you're activating them in some way, as we said. But there's pointless doing a root canal on a tooth that's not going to be restorable. So I agree with you 100%. When we're doing root canals, we know a lot of the time the tooth are going to be crowned afterwards. So we're not going to sacrifice the crown in terms of missing anatomy or determining restorability or cracks or other things on the tooth. So I'm with you, getting the rubber dam on, taking the tooth out of occlusion, removing crown if that's going to impede. And I'm not a great fan of these ninja accesses. You need to take out as much as you can, to allow you to see the restorative aspects of the tooth and help you with anything that's going to make sure that you're looking for the MB2, you're troughing for distal canals, mid-mesial canals, and you need some space for that.
And you know why I love Stephen Buchanan so much, if not the most? You know why I love that guy? Because it was his lecture who, first I was mad when he said, for this irrigation and you can activate and all this stuff, he says, but what I do is I just let it soak in there. After I'm all done, I let it soak in there for an hour. And I'm like, an hour? Are you serious? And I thought, well, you just doubled the cost of a root canal. It's too long and all that kind of stuff like that. And then I realized, oh my God, that was the practice management holy paradise, because I'll be doing a root canal and my time's up and I need more time, but I'm out of time. And then I just tell the patient, I say, look, here's the deal. It's an infection. It's not the tooth. And it's Dr. Steve and L. Buchanan, and he's this great teacher in California. And he says that to increase the success rate, you just need to let this bleach sit here and soak for an hour. Are you good with that? And they're like, oh, yeah. I mean, hell, I just paid $1,000. So now I got, the assistant in there sitting with them for an hour. Well, I can stay on schedule and get another stuff done and then come back and finish. And that's what he likes. So how's that for letting it clean?
Yeah, well, I think the cleaning is critical. And whether you're, warming the sodium hypochlorite using full strength versus half strength, there's actually, we found out a lot of the new sodium hypochlorites have surfactants in them. One of them is, I think, smear off is one, where it kind of increases wettability. But what I do know is, what I've heard is, when we had Ebola and the CDC goes in to clear up an area, they put a tent around the area and they sprayed with sodium hypochlorite. So sodium hypochlorite is still probably the standard rinse that we have. And then we can augment that with additional, whether it's something like MTA BioPure, which has doxycycline, or a Q-Mix that has a mixture of chlorhexidine. But I'm a firm advocate of irrigating. If you're going to irrigate, use 20 to 40 cc's. Be very liberal with your irrigation. Use a safe needle, 27 gauge, sometimes a 31 gauge for really tight canals. But you can't over irrigate a canal, and sodium hypochlorite left in a tooth, I have no issues with it. I think it's great, especially in cases that are necrotic or retreatments where you got active infection going on. I don't think there's any harm. I don't think I've ever left sodium hypochlorite in a tooth for an hour, because in that situation, if I have to read them, then I'd probably fill the canal with something like calcium hydroxide and maybe bring them back another time. But I don't think there's any, the sodium hypochlorite is not going to dissolve your tooth in an hour. So irrigation is good.
Okay, but you just walked into a great question that they still ask on Dental Town. When can you do the molar root canal in one appointment, and when does it need to be done in two?
Yeah, great question. I think if the tooth is vital, it's like any time in surgery, when you get your gallbladder, people don't go in 4 times to look at it, play with it. They go in there, in any type of surgical intervention, including endodontics and oral surgeon. The oral surgeon, the quicker they take out your wisdom tooth, the less trauma it causes. So if you can go in and out, that's the best surgical. If you're following all the protocols and you can go in and out, in my opinion, there's solid evidence for that. So if the tooth is vital, whether it's a reversible, irreversible pulpitis, or you're doing an elective root canal, all of those can be done in one visit. If you follow if you find the canals, if you get patency. What's more important in endodontics, I think, is the concept of patency. You got to be able to get to the end of the canals when you find them and remove the causative issues, which is, either inflamed or necrotic pulp tissue. In cases of where you have a swelling or you can't dry the canals, and those are always associated with necrotic cases or in retreatments. In situations like that, I think it's okay to go 2 steps. But most of the time for fresh root canals, reversible, irreversible pulpitis, if you can get it done in a timely manner, those should be done in one visit. I can argue that it shouldn't be done because every time you go in there, you're going to introduce bacteria in the tooth. Even if you're using a rubber dam, you're going to over-instrument. There's going to be more time. You don't spend 2 hours cutting a crown prep, because by the time you're done, you're going to get a pyramid. You're going to go in there, cut the crown prep in 7, 8 if you know what you're doing, and you're going to be in and out. So I think the same concept applies in endodontics. Okay,
the other question is, what advice would you give? What tool can I buy to help me find that MB2? That like I said, I'd pay the $85,000 for a Son Endo Gentle Wave if I could just find a machine that'd find the damn MB2. So what advice would you give on someone trying to find an MB2?
Excellent. One, I would follow your recommendation first. Make sure that your access is large enough. Remove the restoration. Make sure the access is large enough. The literature is clear. The MB2 is usually 2 to 3 millimeters. So, you got to trough somehow. You got to be able to trough. Now, you can use an ultrasonic unit to trough, or you can use a long round burr. A good friend of mine, John Muntz, we've lectured together. He's the inventor of the Discovery burr. I think those are great burrs, long neck stainless steel burrs that you can, but you have to trough. And to be able to trough effectively, you need either a microscope or you need headlights and magnification, usually about minimally, I would say 3.5. But if you have some form of magnification and enhanced lighting, and you can trough, that's what you should do. And you would trough, you would draw a straight line from the MB1 to the palatal, and you would trough, when we do our courses, because our courses are specifically focused on, locating MB2s. You should be able to trough 2 millimeters down and 3 millimeters straight line from MB1 to palatal. And you should cut dry. If the tooth is vital, you're going to get a little bleeding. You should never trough wet, because if you trough dry, you're going to get the powder, the dentinal powder is going to go onto the MB2 area. Now, what we found, because every root canal we do, you're going to get 2 canals filled in the MB1, even if we don't find it, because we know a lot of times it's related to an isthmus. So you need to have some form of a reciprocating handpiece that you can trough from MB1 to the MB2 location. You can clean out a lot of the little dentinal triangle there, because more than half the time, these don't have separate portal of exits, POEs we call them. So if you're going to trough, good magnification, ultrasonic or a round burr to trough dry, and lots and a good access.
Okay, I'm sorry for keeping you so long and so much overtime, but these are just routine questions that just keep coming out of dental school. The tooth's dead. She knows it's dead. That needs a root canal. She takes out the MOD amalgam, and there's a crack on the floor. And she's like, "Okay, is it hopeless? It's a black crack on the floor."
Yeah, I can just tell you, the last, when we were at the American Association of Endodontics, the last meeting, we probably had maybe 20% of the lectures were around this kind of cracked tooth syndrome, and cracked teeth. In my opinion, and again, you can argue both sides of this. So I'm saying, if you have a crack, the cracked teeth are most common in the lower second molars. So lower second molar is going to be your most problematic tooth in the mouth. One, because the mandibular canal is very close to the end, and it's highly, if you're going to talk to a patient and try to save the tooth, please, under promise and over deliver. Let your patient make the choice. You tell your patient, Mrs. Jones, there's a crack on this tooth. This is like a win, I didn't cause the crack. I can promise you I didn't cause it. My kids didn't cause it. It's the location of the tooth on the lower second molar. You're taking a lot of masticatory forces, your masseter temporalis muscle. There's a crack there. The best, if you have thermal sensitivity with that, we can take care of it 100% with a root canal. A root canal will take care of that. Now, if you have a crack without thermal sensitivity, but with biting discomfort, you may always have sensitivity on this because the crack probably goes towards the periodontal ligament. So if you want to, every time you eat a steak or you eat a raw carrot, you're going to have sensitivity on that tooth. So if you can live with that, we'll take care of the root canal and the crown. If you want 100%, you don't want to feel anything, Mrs. Jones, we got to take that tooth out, bone graft and implant at $4,000 to $5,000. You choose what you want done. Because I think our cracked tooth for endodontists is like a full denture for general dentists. You don't want the patient coming back every week. And I think when I lecture or I talk to my group or my general dentist partners is, if you have a crack on the floor, there's no periodontal ligament, there's no perio associated with it. If it was my own tooth, I would get a root canal and crown on the tooth. And I would live with the fact that if I'm going to eat a steak or a hard carrot, I'm going to feel it a little bit, and I'm happy to live with that. And then we follow up with radiographs in the absence of pathology. A lot of patients live with it and get used to it. Now, if you get the patient who wants 100%, they don't want to feel anything on that cracked tooth, then it's their choice. Take the tooth out, place an implant there.
Okay. My sister, my oldest sister, Mary Kay, who's a nun, she's Sister Annie Yahweh for 30 40 years. It always tells me that, that the golden rule, treat other people like you want to be treated, is found in every major religion, Hinduism, Islam, every religion. You can't find a name of a person, place, or thing in all the major religions, from Hinduism to Judaism to Christianity, Islam, except for the golden rule. And one of the problems I have with the golden rule is I would only let an endodontist do a molar root canal on me. I would never go to a general dentist. I've ran Ironmans with dentists that would probably do the best molar endo ever, but I'd still go over to Jason Hell or Brad Gettleman or, an endodontist. So I really like this specialty thing coming in because it doesn't violate the golden rule. I like it monetarily. Money's the answer. What's the question? Because the insurance companies are going to pay me more money. I like it legally because America has 1 million attorneys, and they're not they're not going to go after a specialist because that's hard to do. They're going to go get the general dentist to get hung by a specialist. So I like all that stuff. The only thing I'm trying to and retail has proven for 2 centuries that put it all under one roof. That's the retail formula. And when I go to Asia, when I'm lecturing in Myanmar and Cambodia and all those places over there, they have dental hospitals. And when you're in pain, you go to the dental hospital. And a lot of these towns, I did a podcast from, I think it was Cambodia. And he had the tallest building in his town, and the first floors were general dentistry, pediatric, and you went all the way up. And there's not a single dental hospital in the United States of America. DSO doesn't even own a dental hospital. But when you are doing your specialty care, I understand, love everything about it, but when you say it's a mobile platform, the mobile part is the endodontist going to your office. You're not doing anything in a mobile clinic, are you?
No, I agree 100%. There's too much dental space. There's no need. There's so much dental spaces. It's almost, as I said, you read our business plan. No, we take the technology. We take a cone beam for difficult cases. We have a.
But are you doing it inside someone else's brick and mortar dental office, or are you doing it in a mobile?
No, the dentistry is all delivered in the general dental office.
Okay. So when you say mobile platform, I'm thinking of an RV. I'm thinking of a driving around dental chair. But you don't do that.
No dentistry. We have a small unit that has all the technology necessary to do complicated cases. The microscope, the cone beam. We have a CAD CAM to partner with our doctor. So in times of COVID, when the root canal is done, the doctor can place his restoration or her restoration at the same visit. We're trying to respect the patient's time and look at it economically. There's no need to build more dental offices when we have so much redundant space in dentistry.
Right. Yeah. That's so. My final question is: so how's the business plan working? How's it? How's demand been? How is it?
Everybody we've talked to has loved the concept. With COVID, it's been a little difficult to get to office because we kind of launched the project in the middle of COVID. But every doctor we've talked to, has loved the concept of being able to have a specialist come to their office for them to be able to monetize their space and to be able to take a cone beam if necessary. And in times when the patient, as you said yourself, to get dentistry at the same time, same day dentistry, for them to be able to get the root canal done and to have a CAD CAM delivered crown on the same day. Those have all been very positive.
And final question, I swear I'll let you go someday. Your course on the Smart 30-minute root canal endodontic course is taught by Ahmad Al-Natur. He's an endodontist down in Tucson. Is he still down in Tucson, or did he move out with you guys to Cali?
No, he was in Tucson. Actually, I helped him build Tucson up when we were in Tucson. He was in Tucson, a great endodontist out of Harvard, board certified. He's up in the Bay Area now, but he's actually one of our senior endodontists, and he lectures the course once a month. So he flies down from the Bay Area.
Wow. Well, you tell that little fancy Harvard boy he's got to come on the show. I mean, he was Tucson, and yeah, have him come on the show. My two boys live in San Fran now. They, you know, when you go to San Fran, they have that cell phone tower.
Yeah.
My boys started a cell phone welding tower business, the oldest two ones, and because they were rock climbers. And when they were going to college and at Flagstaff, these people would come by and they'd bribe. I remember Eric called me out one day and says, this man's offering me like $500 if he takes me on a 2-hour drive and I climb to the top of this tower and pull off this Verizon box. And I said, well, can you kick his ass? And, you know, because they all wrestled. And he goes, yeah, I'm not worried about that. He goes, I said, well, go do it. Turns out no one that will climb a cell phone tower. And so to be a welder and a cell phone tower, so he said, well, let's learn welding. We already love cell phone tower. But that San Francisco cell phone, they've kept him busy for 2 years, and they're making more money than dentists out of dental school, and they're having the time of their life trying to, you know, kill their dad. You know, they'll be hanging upside down, taking a selfie, and their truck looks like a little matchbox car. But and talk about a vital business. I mean, during the whole COVID thing, they were telling the cell phone towers, we're not, you know, keep cell phones going 100%. We're not going to do that. But yeah, I'd love to get a mod on there and talk all things endo, because again, they're in pain and they're begging you to do the treatment, as opposed to you going to some cosmetic course and trying to convince someone to get bleaching. But I mean, if I told a woman, you know, you really should bleach your teeth, she's probably looking at me saying, well, why don't you lose 30 pounds and then get back to me? You know, I mean, I'm not going to tell some woman she needs to bleach her teeth or bonding or veneers. But my gosh, kids, if you can pull a tooth and do a molar root canal, you're a real doctor, and there'll always be a need for you. And I want to thank you two guys for coming on the show today. And you were supposed to give me an hour of your life, and I stole 2. You gave me 1, I stole the other one. And anything you can do to spread your message on Dental Town, let me know. If you ever want to do an article in Dental Town Magazine or put up a online course, or you said that you'd put that COVID one on there. So I'm Howard at Dental Town. The other Howard is Howard Goldstein. He's in charge of all the online CE and all that stuff. So he's HOGO, H-O-G-O at Dental Town. But the endo courses always do well, because they you know, they're just hard. There's no doubt about it. They're hard. So thank you guys for all that you do. Thanks for coming on the show. And my gosh, if you can get an endodontist to come into my office in Phoenix, love you for life. That would be great. And again, the reason is we do all of our endo. We don't have a problem with that. Well, we refer endo, but again, it's not about me. It's about the damn patient. My patients don't want to come in to find out they got to go somewhere else. They want to come in and get it done. And it'd be really nice to know that we could just say, yeah, these 2 days a month, come in and they'll do the endo.
It's been our pleasure, Howard. Thank you so much for having us.
Thank you, Doc.
And get that MTA doc on.
Yeah, Dr. T. Yeah.
That perfect. That's what I'll call him, Dr. T.
Everybody calls Dr. T.
So there's one last thing. There's 2 stories. There's Dr. T and Perry Radcliffe. The legend has it that Perry Radcliffe, and he told me this himself at dinner right here in Scottsdale, Paradise Valley, that he was sitting there looking at his pool and he realized, I live in a desert. It's 115 degrees and I can see the bottom of the swimming pool. If I go to any lake in the whole country, you can't see 3 inches down there. It's just chlorine and acid. And when you lower the pH by 1, it doubles the free release of hydrogen ion. And boom, that was the invention of Perry Radcliffe and Omar Reed's retardant mouthwash. That was chlorine dioxide, and I love it, but I don't buy it because it's swimming pool water. When I want to rinse my mouth with a swimming pool, I pour my beer out, stick it in the swimming pool, and then I swish with it. And then, but you know, I'm a classy guy, so I don't spit it back in the pool. I spit on the side. And the other deal is Dr. T, same thing. Perry Radcliffe said it was a gin and tonic, and I think it was him who told me the same thing with Dr. T. He was also sitting by a swimming pool drinking a gin and tonic, and the swimming pool repairman guy was using the swimming pool repairman putty. He says, "Oh my God, that's cement that works underwater in a swimming pool," and that was the birth of MTA. So he's tell him to either come on the show and tell me if that story is true or false.
The story's not true, but it was close.
Oh my God! But Perry's is true, so at least we got one out of 2. But the story's not true.
No, but I think the story goes because I was involved with MTA during the development. Dr. Tora.
So you were the pool boy.
Yeah, I
You
was
were the
pool
pool
yeah.
boy fixing Dr. Okay, now I'll change the story to where
I was
you
the
were the
pool
pool boy.
Yeah.
Do you have a picture of you cleaning the swimming pool while he's sitting there on the side?
I'll send it to you.
All right, guys, have a great day. Thanks for coming on the show.
Thanks a lot.
Thank you so much.